Hi everyone! Today we're going to go over some pharmacologic updates from the American College of Cardiology World Congress of Cardiology 2020 virtual meeting that was held a few weekends ago. We're going to go over 4 trials today. The first, colchicine post-MI, actually came out in December, but it's something we haven't covered in this pharmacy update series, and I think it's important to be aware of. We'll talk about apixaban in cancer-related VTE, rivaroxaban in PAD status post-revascularization, and then an ongoing trial looking at e-cigarette use for tobacco cessation. First, we'll review the COLCOT trial, efficacy and safety of low-dose colchicine after myocardial infarction, published in December of 2019. The purpose was to evaluate the anti-inflammatory benefit of low-dose colchicine in patients recently post-MI. They looked at just under 5,000 patients with an MI in the past 30 days, and you can see the exclusion criteria listed there. They randomized patients to colchicine 0.5 milligrams daily versus placebo. Now keep in mind we have 0.6 milligrams colchicine approved here in the US. There was a large composite outcome comprised of death from cardiovascular causes, resuscitated cardiac arrest, MI, stroke, or urgent hospitalization for angina leading to revascularization. Baseline characteristics of the 2 arms are listed below. Importantly, looking at medication use, over 97% of patients in both arms were on aspirin, another antiplatelet agent such as a P2Y12, and a statin. And you can see right under 90% of patients were on a beta blocker. For the primary composite outcome of death from cardiovascular causes, resuscitated cardiac arrest, MI, stroke, or urgent hospitalization for angina leading to revascularization, there was a statistically significant reduction with the use of colchicine daily, with the number needed to treat of 63. Listed are the individual components of the primary outcome. We can see that the composite outcome was driven by reduction in stroke and reduction in urgent hospitalization for angina leading to revascularization. Finally, we have the adverse effects from the two arms. We actually didn't see a statistically significant difference in general GI effects or diarrhea, however, slightly more nausea and flatulence in the colchicine group, which can be expected, and then also interestingly, an increased risk of pneumonia in the colchicine group, which the investigators were unable to explain. In conclusion, the Colcott trial found that the addition of low-dose daily colchicine to a baseline regimen of guideline-directed medical therapy was actually beneficial for reducing outcomes in patients who were recently post-MI. And this reduced risk was driven by hospitalization for angina and stroke. The next question is, what about the cost effectiveness of adding another medicine on top of all these other medicines for patients? This cost-effectiveness evaluation of the addition of colchicine therapy was presented at ACC the other weekend. They looked at cost-effectiveness from a Canadian universal payer perspective, as well as from a U.S. Medicare and a U.S. private insurance payer perspective. So looking at those bottom two bullets relates to us here in the U.S. They did find that the addition of low-dose colchicine was cost-effective as long as the cost was less than $5 per pill. So it's important for us to keep in mind to obviously select the formulation of colchicine that is preferred on the patient's insurance. All of this to say, we might start seeing the addition of colchicine after MI for patients optimally medically managed, not just used for gout. Next, we'll look at the very exciting Caravaggio trial, which looked at apixaban for the treatment of cancer-associated VTE. The Caravaggio trial was conducted to determine if apixaban was non-inferior to dalteparin, a low molecular weight heparin like enoxaparin, for the treatment of proximal DVT or PE in patients with cancer. They looked at 1,100 patients with either active cancer or a history within the past 2 years of cancer with a newly diagnosed proximal DVT or PE. You can see there were some certain types of cancers excluded, some drug interactions that could exclude patients, as well as a creatinine clearance of less than 30. Patients were randomized to receive apixaban therapy with a DVT-PE treatment versus dalteparin therapy. The primary efficacy outcome was recurrent VTE event, and safety was the European Medicine Association definition of major bleeding. Within 72 hours of the confirmed DVT or PE, patients were randomized to receive either apixaban 10 milligrams twice daily for 7 days, followed by 5 milligrams twice daily, or subcutaneous dalteparin 200 units per kilogram for 30 days, followed by 150 units per kilogram for the remainder of treatment. Patients were treated for 6 months. The groups were fairly well matched at baseline. We could see the average age was around 65 years and about half were male. We can see that around 55% of patients had a PE with or without a concurrent DVT, whereas right around 45% had a DVT only. About 20% had active cancer versus a history of cancer, and right around 8 to 10% had a previous VT. On the left, we see the Kaplan-Meier curve for the primary efficacy outcome. On the right, the primary safety outcome. We see that apixaban was non-inferior to dalteparin for treatment of VTE and prevention of a recurrent VTE within 6 months. And on the right, we see that there was no significant differences in bleeding. However, apixaban trended towards less bleeding. You can see right there around the 90 to 120 day mark. Particularly, no significant differences in GI bleeding, which we like to think about with our DOAC agents. In conclusion, apixaban was non-inferior to low molecular weight heparin for the treatment of cancer-associated VTE, and we saw no difference in bleeding, particularly no increase in GI bleeding. When thinking about our DOACs, we sometimes have to think about GI bleeding, particularly with rivaroxaban and edoxaban, are two other agents that have data supporting their use in cancer-associated VTE. So this may lead us to believe that apixaban may be a bit of a safer agent in our cancer patients who have a higher risk of GI-related bleeding. So all in all, we now have data for the use of Eliquis in cancer-associated VTE. Next, we'll review the Voyager PAD trial, which looked at rivaroxaban for PAD after revascularization. This trial is going to add to the body of literature established by the COMPASS trial, which is looking at low-dose rivaroxaban in addition to other therapies for PAD. Now, you might ask me, Katie, we have the COMPASS trial that showed us that rivaroxaban was useful in PAD, but we really haven't seen that used very often. How is this trial going to be any different? The Voyager PAD trial is really looking at the acute post-revascularization phase for the addition of rivaroxaban therapy in comparison to the COMPASS trial, which looked at stable peripheral artery disease. Other differences is the Voyager trial is looking more at symptomatic patients with PAD, whereas COMPASS had a broader definition of PAD. The outcome in Voyager is looking at some cardiovascular events, but primarily severe limb events, whereas the COMPASS trial was looking at a MACE primary outcome. And the Voyager trial The Voyager PAD trial looked at around 6,500 patients, at least age 50, with PAD. This was defined as an abnormal ABI, imaging evidence of occlusion, and ischemic symptoms, who were status post as successful lower extremity revascularization. They excluded patients with asymptomatic disease, patients who had indications for other antiplatelet or anticoagulant agents, patients with need for long-term dual antiplatelet therapy, or patients who were deemed to be a high bleed risk. Patients were randomized to receive low-dose rivaroxaban, that 2.5 twice daily, versus placebo, and then they stratified patients based on presence or absence of concurrent clopidogrel therapy, and then the method of revascularization. The efficacy outcome was a composite of acute limb ischemia, amputation, and then MI, stroke, or cardiovascular death, whereas the safety outcome was TIMI major bleeding. At baseline, the average age was around 67, about a quarter were females, 40% had diabetes, and 35% were current smokers. Around 20% had a reduced EGFR. A third of patients had coronary artery disease at baseline, 11% had a prior MI. Like we said, 50% were on clopidogrel in both arms, and then around 80% were on statin therapy at baseline. There was a statistically significant reduction in the composite primary outcome with the addition of rivaroxaban 2.5 milligrams twice daily in patient status post-revascularization. We see our two curves really begin to separate around 6 months or before 6 months and continue to separate up through the 3 years of follow-up that this trial did, with the numbers needed to treat around 65 at 6 months, all the way up to only 39 at 3 years. Of that composite outcome, the only component that was individually statistically significant was acute limb ischemia. So this outcome was driven by a reduction in acute limb ischemia with the addition of rivaroxaban therapy. I thought this was an interesting graphic presented at ACC the other weekend that compares the change over time of the risk of bleeding and the benefit from therapy. We see that the risk of bleeding with the addition of this therapy kind of increases over the first 90 days, but then stays fairly stable after that. However, the benefit from the addition of rivaroxaban therapy continues to improve over time. The other thing highly touched on during the ACC 2020 presentation was the presence of clopidogrel and whether adding rivaroxaban on top of clopidogrel would confer additional benefit and what the risk of having aspirin, clopidogrel, and rivaroxaban on board might be. We can see that regardless of whether the patients had clopidogrel therapy, rivaroxaban did reduce the primary efficacy endpoint. And we do see, however, those patients that also had clopidogrel therapy at baseline did have an increased risk of bleeding, which makes sense. So these are all things for us to take into consideration as we see these patients post-revascularization and help decide In conclusion, the Voyager PAD trial added to the body of literature supporting the use of low-dose rivaroxaban in PAD, this particular time showing that there was a reduction in particularly acute limb ischemia in patients who were given rivaroxaban status post lower extremity revascularization. Understandably, there was an increased risk of bleeding. There was numerically, but not significantly, increased TIMI major bleeding. However, one of their secondary outcomes was ISTH major bleeding, which there was a significantly increased risk of that with the addition of rivaroxaban therapy. The final question is really where P2Y12s fit into this. We don't have strong data supporting the use of P2Y12s in this situation anyways, and so where do they really fit in? Should patients receive triple therapy, dual antiplatelet therapy, DOAC plus aspirin? We still need further randomized controlled trials to help us parse that out. I wanted everyone to be aware of a trial that is not published yet, but was presented at ACC, which looked at the efficacy of e-cigarettes for smoking cessation. The E3 trial is being conducted to evaluate the efficacy and safety of both nicotine-containing and non-nicotine-containing e-cigarettes in combination with counseling compared to counseling alone for smoking cessation. They have 376 patients enrolled. They had planned for more. However, with everything going on with e-cigarettes, there were limits to production, and so they had a smaller sample size. They are looking at patients who smoked at least half a pack per day at baseline but were motivated to quit smoking, and stratified them to 3 arms: nicotine-containing e-cigarettes plus counseling, non-nicotine-containing e-cigarettes plus counseling versus counseling alone. The primary efficacy that they reported during this presentation was abstinence at 12 weeks, and secondary, they looked at reduction in cigarettes per day and continuous abstinence. And then finally, they looked at individual serious adverse effects in each of these patients. At baseline, the average patient was around 50 years of age and around half were males. Patients had been smoking for about 35 years and were currently right at a pack per day. Around 90% have tried to quit before. You can see a bit of a variability between how many have tried e-cigarettes before. Right under 20% have concurrent heart disease, and right around a quarter have concurrent respiratory disease. At 12 weeks, 22% of patients in the nicotine-containing e-cigarette group had quit smoking, 17% in the non-nicotine group, and 9% of patients who had just received counseling. There was a statistically significant reduction in the use of nicotine e-cigarettes and non-nicotine e-cigarettes versus just counseling alone, with numerically more, as you can see, patients quitting with nicotine e-cigarettes versus non-nicotine containing e-cigarettes. Additionally, there was an overall reduction in the number of cigarettes patients are smoking at 12 weeks. Remember, the baseline mean cigarette smoked was 21 across all 3 groups. At 12 weeks, the nicotine arm mean was 8 cigarettes, non-nicotine was 10, and counseling had been reduced to 14 from the baseline of 21. As you can see, there wasn't really any sort of trends or patterns of certain serious adverse events. And again, this was only over 12 weeks though, so it's hard for us to really follow what kinds of adverse events may be higher in patients who are using nicotine e-cigarettes versus the non-nicotine e-cigarettes versus counseling alone. In conclusion, the use of e-cigarettes, whether they contain nicotine or not, in addition to counseling, was more beneficial than just counseling alone at 12 weeks, which is understandable. We know that using things like nicotine replacement therapy is more beneficial than counseling alone in patients who are trying to quit smoking. There was a smaller benefit, but still a benefit, in patients who use non-nicotine containing e-cigarettes, which may be something interesting to think about moving forward. However, we do still need longer-term data regarding the safety of e-cigarettes. As of right now, the thought is that most of the vaping-related lung injuries were really related to the THC oil components and vitamin E within the vaping products. So it's hard to really tell if non-nicotine containing e-cigarettes are safe. We need longer safety data. And so this E3 trial, they are following patients for a full year and will eventually report the outcomes associated with that. Please feel free to reach out with any questions, and a special thank you to Emily McElhaney, the PGY2 cardiology resident, for helping me parse through an entire weekend's conference of trials to figure out what might be most beneficial for primary care.